Of course, I'm a consultant for Wright, so there is conflict of interest on that behalf. But as this is a corporate event, you'll see that we've worked hard at designing this implant that we're going to show you later tonight. Bunions can be humbling. I think we all appreciate the chevron osteotomy that shows up, that we can help get better and fairly predictably. But the more bunions you do, the more trouble you run into. And this is one that had recurrence and lesser toe trouble and a whole mess of issues. And of course, the dreaded hallux varus can really set you back when that shows up to your office. And we learned that it's the practice of medicine. It's evolving. And if you evolve in practice, you try to consistently get better. Hodges, I remember telling me along the way, shame on you if you're doing everything the same way you did it in fellowship as you get out into practice. And my partner here in St. Louis, Jeff Johnson, has consistently said that he's better now than he was 5 years ago. And he was better then than he was 5 years before that. And so you have to continue to evaluate where you're at and try to get better along the way. And I think that's what's happened with me in my practice with bunions. When I started out, I would basically look at an IM angle less than 13 degrees and do a chevron osteotomy, fairly predictable, sometimes add an Aiken, and felt good about that result. As I came out of fellowship, for these middle IM angles of 13 to 17 degrees, I would use an opening wedge osteotomy. Felt like I did a ton of those and had some good results and some not so good results, some varus, also some concern for stiffness at the joint. But when I started out, that's where I was. And I really only used the Lapidus for an IM angle of greater than 17 degrees or a revision situation because it was a bigger operation. And there was some concern about union rates and getting optimal reduction. And so it really was not a big part of my practice. The pros of the Lapidus, of course, are that it's a powerful correction. You can restore more normal anatomy. The cons is that at times it felt technically a bit cumbersome. Having to prep the joint, possibility of bone graft. Do I use screws? Do I use plates and screws? Is there a concern for non-union? And as I started in practice, it just didn't feel like a go-to operation for me. As I evolved, if I had to do a Lapidus, my first goal was just fuse the joint. Just get it to fuse and get out and try to avoid any trouble. So as I would approach bunions, I would do a bunionectomy. I'd prep the first TMT joint. I'd reduce the IM angle with the clamp and really just reduce it in the coronal plane, trying to get the IM angle reduced. And then we use a cannulated lag screw. Add a neutralization plate, and then hope that the darn thing would heal up. And so I had some okay results, and here's an example of one that I did early in practice and just wanted to get that joint to fuse without non-union. And typically they healed. The correction was okay. The plate felt a little bit cumbersome at times, but some patients did very well. And here's another example of a Lapidus that I did. And the problem is I followed these patients out. This is what that same patient looked like several months down the road. And as I look at their pre-op image, I'm not sure I actually helped this patient at all. They're different, but I'm not sure they're much better. And I started thinking about this intercuneiform joint and was there issue at the intercuneiform joint? Because if the TMT joint is fused, where else could the deformity come from? And so as I then evolved, I said, well, not only do I have to get the TMT joint to fuse, but I need to address the intercuneiform joint as well. And so here's a poll question that will come up for the audience, and we would ask you to click on your best answer here. How prevalent does the audience think that intercuneiform instability is in severe to moderate bunion deformity? We get an answer there. So I think most of the audience selected 50 to 75%. And certainly I've seen some studies that have cited that as a value, looking at trying to evaluate the foot intraoperatively. I think we can all attest that there is intracuneiform stability. It's there and it's real. And so as I move through, then I would do the bunionectomy. I'd prep the first TMT joint. I'd reduce the IM angle with the clamp, reduce that splay between the first and second metatarsals, use a cannulated lag screw, use a neutralization plate, and then I started adding a 1-2 IM screw. And I like that because it would help me dial in correction. If I didn't have enough correction, I could twist that 1-2 screw a little bit more. Felt like I could close down that intercuneiform space. They typically healed. The correction was better. I felt like I could dial in that screw. And again, some patients did very well. My issue here was screw traffic. I felt like I had to sort of figure out a way to split the uprights between the plate screws. It just didn't feel like it was as smooth an operation as I wanted it to be. So then I said, well, gosh, maybe I need to try to avoid screw traffic. Is there a different way to do this without feeling like I'm running into myself? So I would do the bunionectomy, prep the first TMT joint, reduce the IM angle with a clamp. I would use 2 cannulated lag screws instead of the plate. And I just gave up on the intercuneiform screw. And I think I made a mistake in doing that in retrospect. But I was just wanting to reduce how much hardware I was putting in there. Admittedly, I was trying to get a little bit quicker and trying to reduce the angle and get a good result. So they typically healed, fortunately. Correction was okay. The fixation seemed okay. That proximal to distal screw would catch the plantar cortex of the first metatarsal, typically get a good bite. That distal to proximal screw, I would worry about that bite within the cancellous bone of the cuneiform. It just didn't feel like I was really locking it home. Again, some did very well. I was certainly faster, had less screw traffic to worry about. But I should have listened to my last iteration where I was doing that intercuneiform screw, because here's an example of a recurrence. And again, I'm not sure I made a whole lot of difference for this patient, looking back at that intercuneiform space. And so then I said, well, now I'm trying to avoid screw traffic, but at the expense of that intercuneiform instability, so maybe I still need to address that. So I would do the bunionectomy, prep the first TMT joint, reduce the IM angle with a clamp, do 2 cannulated lag screws, and then add an intercuneiform screw. And here's an example of that. Now, as I did that, I chose to do it at the intercuneiform joint between the medial and middle cuneiforms with the thought that it would kind of get out of the way of some of that screw traffic that I was concerned about. What I didn't recognize is that despite the fact that they typically healed, the fixation seemed okay, the same concerns at the first TMT joint, there would still be concern for recurrence. And I wish I had seen a study that was published later on looking at different intercuneiform screw configurations where they identified that there really wasn't much help or much difference in force resistance at the intercuneiform joint with this medial to middle cuneiform screw. And that a screw between the first and second metatarsal, or a screw oblique across from the first metatarsal across into the middle cuneiform, provided more mechanical structural support. And so here again is recurrence. Not sure I helped this patient either, and unfortunately with concern for recurrence at the intercuneiform joint. So I still needed to address that joint, but I needed a better bite. At this time, I'm getting frustrated with my Lapidus procedures. I'm reaching out to colleagues. I remember talking to Hodges, who mentioned the screw that was more of an oblique screw. He had talked to some folks in Columbus, Dr. Heyer, Dr. Burlett, and it seemed like a reasonable option to get an intercuneiform screw that was oblique to get a better bite. And so here's an example of that. So I'm using 2 screws, and now I'm doing an oblique screw where I'm trying to get those threads to capture the cortex of the intercuneiform joint, at least of the middle, and ideally of both the medial and middle cuneiform. And this seemed to be a little bit better correction. I still had screws across the first TMT joint, and I didn't love that because sometimes I wouldn't get the bite that I wanted there. But the oblique screw seemed to capture the intercuneiform cortices with a more consistent bite and a more consistent correction. Well, while this is going on, the concept of triplanar correction becomes a thing. And I have to give credit to the Lapiplasty group for really publicizing this concept of rotational correction at the first metatarsal and with bunion correction through the TMT joint. And I started thinking about what this thing was all about and what is it? What does it mean? Is it really there? And at first I thought it was a little silly. There's certainly some clinical data on rotation. 87% of patients suggested to have rotational deformity and a 12 times increased risk of recurrence if the rotational plane is not addressed. And so maybe there's something to this. So I started thinking about it. It seemed a little out there, and I always had just thought about the IM angle, but we really know with bunions that there is pronation. It's the whole concept of how the sesamoid sublux laterally, how we see some rotation through the MTP joint, and we see that as those sesamoids sit more laterally, there has to be pronation through the joint that allows that deformity to happen. And rotational correction really is probably the best way to address this. And I thought about my successes. The sesamoids seemed right when I had good results. And this concept of the round sign was gone. And so when we saw that, and I started thinking, well, maybe the sesamoids, maybe they got to get under the metatarsal. Maybe there is something to this rotation. And I certainly looked at the sesamoids in my recurrences and saw that they were subluxed and that it looked like the metatarsal has twisted. I started thinking that I needed to really think about this rotational correction. And sometimes I think I just got lucky where I incorporated a rotational correction in my bunion correction for the patient. but I thought there was something to it. So now I would do the bunionectomy. At this point, I would use a pin distractor at the first TMT joint represented by these blue bars here. And I did not use flat cuts. I was concerned about shortening. So I wanted to prep the joint and really allow for a rotational or smooth correction still with that position so I could kind of dial it in. I'm sort of paralleling to what happens at a first MTP joint when we use cup and cone reamers. But no reamers here, just preserving the more round surface at the TMT joint. I'd remove the cuneiform pin, and then I would rotate the metatarsal using that pin distractor pin that was still in place at the proximal first metatarsal. I would do that until the sesamoids looked right, until the toe looked like it was sitting flat to the ground, till the toenail looked like it was sitting straight up. And then I would clamp the IM angle at that point after holding the correction in the rotation. Would use the oblique lag screw crossing a cuneiform joint, remove the last pin from the distractor, and place a locked compression plate to augment fixation and allow for a more secure compression at the first TMT joint, where compression, as we know, in most healing and fusion surfaces certainly is important to try to get bone to heal. And so here's a case of one of my early thoughts in using this rotational correction. This was a woman who only had an IM angle of 14 degrees, hallux valgus angle of 29 degrees, but you can see from her clinical picture that that toe is way underneath the second toe, and it's rotated well around with a fair amount of pronation. So I thought that the Lapidus was a better tool for this patient. So I would do a first web space release. I release the joint capsule and the sesamoid sling. I work down, so I separate some of the connections between the sesamoid sling and the metatarsal laterally. I also still transect the adductor as it inserts on the lateral sesamoid. And if I can passively correct the toe, then I feel like that's enough of a lateral release, certainly to try to help release those sesamoids and allow them to sit beneath the metatarsal with the rotational correction. I like a V to Y capsulotomy, expose the medial eminence, but not resect the medial eminence until the correction has been completed. Here's the pin distractor. Here we are intraoperatively. Now the joints have been prepared, and I use that pin in the metatarsal to create the rotational correction. And so here's an example of that. I've eliminated that round sign, and here now I can place the clamp. And as we look intraoperatively now, the clamp's in place. I can see the obliquity of the pin in the proximal metatarsal showing the rotational correction. And here's an end-on view where you can see how that metatarsal has been rotated out of its pronation deformity. At this point then, the clamp was in place. I would put that oblique screw across the cuneiform and then add a dorsal plate with compression through the plate and then stabilization. You can see here that those threads are nicely crossing the cuneiform joint and allow for a consistent bite there. I think getting those cortices really makes a difference, and I don't think there's enough motion at that joint to create pain. Knock on wood, I have not seen one of those screws break, but I do believe maybe it could over time, but I have not seen that happen and really like this as a consistent purchase for that cuneiform stability. Resect what's left of the medial eminence and then do a capsular repair, and here's the completed toe prior to Aiken, which then helped further the correction. And so as I looked at this rotational correction, I really did think there was something to it. Here's another example. And I found that I was getting appropriate and more consistent results. So I would rotate the toe until it looked straight. And honestly, if the toe aligns without a capsular repair, then you know you've hit a home run on your correction. The fixation was more consistent, was better. The lag screw would be fixed across the cuneiform joint. The plate fixation would add stability and compress through that plate. And the foot just plain looked better. And I felt like I was getting to the heart of the action here. Importantly, I was getting more consistent result. Here's another example. Again, more consistent result and felt better about it. So now I needed to remain consistent, and I wanted to help refine the technique, and was lucky to be involved in doing that with Wright Medical. What I didn't like about the clamp that we had was that the tine on the metatarsal head would often slip. So you'd get your correction, you put that tine on, and sometimes it wouldn't hold. Sometimes you'd accidentally knock it with your other hand. The tine on the second metatarsal neck would slip around oftentimes and lose some of your compressive force. And so if you lost your reduction, it was very frustrating, and you'd have to try to reapply that clamp. So we set out to try to make that clamp more reproducible and to help with consistent results in correction. So we looked at a triplane reduction clamp to allow for correction of the IM angle, any plantar flexion improvement that you wanted through the TMT joint, and then rotational correction. And then importantly, once the correction was obtained, it needed to remain stable and hands-free once the clamp was in place so that you could move towards your fixation. So compression here through the slot to create reduction of your IM angle. You can push the implant down, the clamp down and help refine the plantar flexion position. And then of course the rotational correction through the sliding rotational bar here. So here's a video from right, and I think it's important to understand that it does start with a pin in the metatarsal head. I like putting it perpendicular to the shaft of the first metatarsal. I know that there's some thought that maybe as you're trying to affect a greater plantar flexion or dorsiflexion correction, you might tweak that angle, but I like it perpendicular to the shaft. And then here's the video as it plays, and here's the example of the clamp. And so what's important is that it moves in all these planes. And so effect rotational correction as we discussed, but now ability to place that clamp over top with one tine around the second metatarsal neck and the other over this pin. And then as you obtain your intramedullary connection, your intramedullary angle connection, many times that rotation will correct itself. You can still affect further rotation, but the nice part is once you lock that knob on top, now your correction is done. And we found that typically this remains fairly stable. And it's nice because now the clamp is in place, it's away from where you're going to provide your fixation. And now that the reduction is in place, it's a matter of placing plates and screws. Here's an example where we use this LapiFuse plate, Freudian slip there. 25-year-old with bunion pain, IM angle of 16 degrees, hallux valgus angle of 25 degrees, and a plano valgus alignment. And so we felt that a Lapidus bunionectomy with the LapiFuse system would be the best choice for her. So here we are, we've skipped ahead after the joint prep, and we see the pin in the first metatarsal head. We see we're pushing that clamp across to the other side of the second metatarsal neck, and we now have our rotational correction in place. And now what's nice is you see I don't have a single hand on that clamp. It's in place, and the rotation has maintained its correction. And now I'm just putting the screw in. There's a targeting guide that you can use if you like. Otherwise, if you're accustomed to the angle of the placement of that intercuneiform screw, you can just apply it without that guide. But you see that there's no hands on the clamp and it's out of the way. And this has really been an addition to the practice of doing these bunion correction that has added to the consistency and reproducibility of getting the correction appropriate. So here's that patient with that IM angle of 16, and there we see the correction added an Aiken to help with correction of the phalanx. And so there she is with her before and her after showing impressive correction. So when I started practice, here was my algorithm. IM less than 13 degrees would get a chevron, IM of 13 to 17 degrees an opening wedge, and IM of 17 degrees or greater or a revision situation would get a Lapidus. As I've evolved, I've really gone away from the opening wedge osteotomy, really using an IM angle of less than 14 for a chevron, and anything greater than 14, certainly with any kind of rotational correction or any kind of pes planus or dorsiflexion deformity through the TMT joint or instability, gets a Lapidus procedure. Other reasons to include, in addition to revision and Lapidus, as I mentioned, increased rotational deformity, and I do that, evaluate that by looking at the foot in stance. Certainly any planovalgus foot or anything that needs medial column stabilization can be improved by using a fusion at the TMT joint in a Lapidus procedure for bunion correction. So I think the take-home points as we work through this, it's humbling to look back at your cases. And if any of you have the opportunity to do it, if you haven't, you really can learn a lot about your thought processes. In this particular situation, I recognize that I should have hung on to that intercuneiform at least 1-2 metatarsal fixation early on, and I went away from it because of frustration with screw traffic. Here, I think, as we learn from data that's in the literature on intercuneiform instability, fixation techniques, Lapidus techniques, learn from your own experience, we recognize that we can improve. I do think intercuneiform instability happens, so why not address it before it's a problem and address it with your initial procedure in those patients who you think need rotational correction and a Lapidus or LapiFuse procedure. And I think stable fixation is the key. We need compression for fusion. We need stable plates and screws that can offer that to our patients. So where am I now? I think we've got it. This has really helped me improve my bunion outcomes with increased fusion rate and happier patients with more consistent correction of deformity. I think we've optimized the reduction using the triplane reduction clamp. I think we've optimized fixation with giving some real thought to the intercuneiform joint and the oblique screw that we advocate. And the lock plate adds an additional level of stability that helps the construct overall. Bottom line, I like the Lapidus. I started out not liking it at all. But with these tools, it's really improved my practice, and I don't shy away from it because I think it gives the patient an optimal result in many situations.